Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator, and yes, this is session number 100. On this landmark occasion, I want to share some observations with you this morning. It has been an amazing journey to bring 100 complex coronary interventions live to you all. You've been a terrific audience, your queries have been thoughtful and they have improved the quality of our procedures. I am often asked how this journey began. Let me provide you with some insights on this occasion of 100 cases. For more than a decade, Dr. Sharma and I had discussed creating an educational platform to showcase our complex interventions. But then both of us were extremely busy and everything kept pending and the project lay dormant. However, it all fell into place on October 22nd, 2008. This is precisely the date and it was in Dr. Sharma's room at the Hotel Radisson during TCT 2008. I vividly remember spending several hours brainstorming the project. It was clear to us that the opportunity was massive. We reviewed the format, discussed the technology, and even evaluated industry support, realizing clearly that the first few sessions we'll have to fund ourselves. There were some issues about logistics, and we decided that the cases would be from Dr. Sharma's room in the cath lab. We would create a recording studio in the back, and I would travel every third Tuesday of the month from Miami and begin the sessions. From that day at 2008 TCT, our focus has been unwavering. Certain other components needed to be addressed, and we began in earnest, and in July 2009, we showcased our first left main intervention with impaired LV function, for which we had used an Impella device. It almost feels like yesterday. The success of the first few programs confirmed to us the sustainability of our model. This model remains unchanged after 100 webcasts. And there are, you will notice, 3 specific components to it. There was an online viewer feedback, which remains vital today. The second part was the performance of the complex intervention, and then there was a supreme didactic performed by Dr. Sharma. We also resolved, most importantly, never to permit any conflict of interest to permeate in our discussions. And today, after 100 cases, I am proud to tell you that this has been unwavering. Our format remains the same, and we have not uttered a single sentence in almost 8.5 years that has conflicted any of our educational goals. We also maintained our focus to continually improve the viewer experience, and we did this by investing in technology so that we could bring to you the sharpest image and the clearest sounds. We expanded our global reach with simultaneous translations into Mandarin and to Spanish. We also embraced social media most enthusiastically, and today you can watch the webcast on various platforms including Facebook, YouTube, and on the CCC mobile app. As a result of these efforts, our viewership has increased. It has actually mushroomed. At its peak, more than 10,000 viewers watched live cases in 134 countries, quite an accomplishment after the humble beginnings in 2009. Also, in 2012, we added our best quality initiative till date. It was to include the appropriateness and utilization criteria for every procedure that we were going to telecast. You would have noticed that prior to our beginning the procedure, including what you will see today, that Dr. Sharma meticulously inserts the indications of the case into the AUC grid. I strongly believe that every PCI procedure should follow this format anywhere around the world, so that appropriateness of the procedure is never in question. For almost every procedure, we also involve the heart team, and I think this constitutes a second important practice that viewers should instill in their own practices. So, although much has changed, more has remained the same. Mount Sinai Heart has maintained its record of having the lowest complication rate and the highest PCI volume in New York State. Dr. Sharma's excellence is now visible in 2 continents, at Mount Sinai Hospital in New York and at the Eternal Hospital in Jaipur, India. Dr. Kinney now heads the busiest interventional cardiology program in the country, and it has been an absolute marvel to watch her skills, her dexterity, and her self-confidence. Both Dr. Sharma and Dr. Kinney have received national and international awards. Congratulations to both. I have continued an unheard of STEMI-only practice now for 16 years. Doing so, I do sincerely believe that I have performed the highest number of short door-to-balloon interventions in the world. There is one final individual whose guidance, support, and blessings, without that this program was not possible, and yes, I am talking about Dr. Valentin Fuster, and I want this opportunity to thank him again for his tremendous support. To webcast 100 consecutive, uninterrupted cases, never edited, has required tremendous offline preparation. I want to recognize the fantastic nurses and techs in the cath lab and the hardest working fellows who make these cases possible. Our IT team of Michael Hellman and Guy Puglisi and our photographers Chris, Tom, and Gary are simply the best in the field. Finally, Kimberly Costo, our superb manager, keeps the wheels churning without a hitch, and she has done that for many, many cases. Our 100th case will be done soon. Going forward, we'll continue to follow our sincere educational goals. We'll further improve technology and keep you engaged with outstanding content. We thank you for your support, and we hope that you'll continue to watch us both live and with our archived cases. With these words, let's proceed to watch complex coronary interventions case number 100. We'll begin by getting an update on our fantastic, the most educational case on record, case number 99, where we had a dissection of the left main. In addition, I have specifically left the introduction of our 2 most eminent guests today to Dr. Sharma. Sameen, good morning. You're there in the cath lab. Congratulations, 100 cases. Anu, congratulations to you. And Sameen, go ahead, tell us who our guests are.
So while completing all that, excellent, you put a summary of last 8.5, 9+ years actually. And key is more important is also want to thank that all these 100 episodes, the Kini did the procedure, but you also flew, leaving all your practice, and all 100th episode you have come here, and really thank you from our CCC Live and Mount Sinai Cath Lab for this excellent dedication to this project which we started 8-9 years ago. So today happened to be 100th, and we wanted to celebrate with, especially, of course, besides performing the case, welcoming 2 key interventionalists in this field, starting with Dr. David Moliterno, who is the editor-in-chief of JACC Intervention, and he is the professor of medicine, University of Kentucky, and he has come here for this purpose. And then Dr. Sunil Rao from Duke. Both great interventionalists. They have their own field in terms of Sunil being in the bleeding and the radial guru for the country. Goal will be that during the case we'll take the input as usual, while Samir will moderate from that side. So with that note, if we start quickly, if we can get to our slides and we'll have, everybody will have a chance to say quite a bit. This is now our main website page, which has really increased the viewers to 10,000 plus. each episode now in multiple countries and so on and so forth. Actually, after USA, the second one is the India. It's very interesting. So these are our supporters. The disclosures.
Samin, should be just the right moment to wish everybody a happy Diwali in India.
That is absolutely happy Diwali in India to our Indian CCC viewers, which are number 2 after the USA in terms of. Now this case, if I think I had to go there, or can we play? How would we play this? Wanted to show. Let me just come this quickly. One case. Sorry, you want to go play? The first. This is the case which you mentioned.
99.
Yeah, case last one. If you should be able to play.
Samin, this single instance has been viewed the most with the maximal number of questions.
Okay. So somehow there is a, I don't know how it, but anyway, the key was we should be able to maybe get a little later.
Right.
The show.
The video clip.
Yeah, video clip.
Okay.
But that patient, which everybody saw and it's on the web anyway, the patient did well, had no chest pain after the left main stenting, which we did put a 5/4 onyx, and CK had about 2 times CK elevation, and troponin 2 did well. Next day we did echo and went home. So just to update, that patient did very well. The question always was that what really caused the dissection versus so. So Anu, you want to make a comment on that case? What was it? That you think it's the dissection of the guide catheter versus?
Let it play.
Yeah.
Yeah. Okay. Here we go.
Yeah.
Yeah. There is looks to be some issue about. So one of the remarks I had made in the opening statement was the clarity. I think the quality of our transmission, which so many people around the world mentioned to us, has truly become fantastic. And I thank all the IT people here who have made this possible.
Yeah. This was the case.
Yes. Here we go.
Yeah. Very complex LED diagonal bifurcation. And you saw it with the guide liner after doing a rota. We dilated, and then this is the injection we are taking, and see what is happening during the end of the injection.
Right.
And you want to comment on that?
Go back to the previous picture,
Here
because there was a lot of discussion here itself. What should be the plan for the LED diagonal? At that time, the burr size was the selection. Remember, we wanted to go because of the angle itself. Rather than 175 was 15 burr, and it took us a long time to even make that turn in the LED with 15 burr. But subsequently what happened is we were not able to deliver any balloon, and we took for the first time the Godzilla. That was what we have there, and after we were able to balloon dilate, and when we took the picture, when we saw that this Godzilla, which we showed that it is actually coated. So it was a 7 French guide, but we had the 6 French Godzilla, but that's not the reason. Since it was coated with the injection, hand injection, it moved, and I think with that particular force you can see that it created the dissection of the left main. So the key point here we made even at that time was that the patient remained stable, had some EKG changes maybe in the anterior leads, and we took this picture to see exactly what extent it was, and we saw that the circ was not involved. That was important decision making for us, that what we do is take care of the LED first and then take care of the left main. The question there was, why not you take care of the left main first then LED? Having done this many cases, I know that if we stent the left main, there is no way we will be able to deliver a stent into the LED through that stented left main. Since the patient was stable, we finished the LED. Even that delivering the stent was difficult, and then we took care of the left main. And same, the next important question was, why did not we decide to wire the circ, or why did we decide to do a single stent strategy of the left main and not bifurcation stent of the left main? If you see, the dissection starts right at the ostium and stops before the bifurcation. So our goal was, if you tack the dissection right at the ostium, with a large stent, the distal dissection will be handled by the proximal stent, leaving the bifurcation alone, and that is what we did. Just stented this is the Onyx 5.0 stent, which took care of that ostial left main dissection, if you see there, and subsequently the LAD flow and circ flow was restored.
Anu,
right?
there are so many viewers who have complimented you and Samin on your very mature and calm handling of the case, and I think it's a fantastic archived case for people to review so that they can manage anything like this.
Absolutely. So, I'm sorry, let's go to.
In the meantime,
we are ready
David
now.
and
Yeah.
Sunil, I extend to you my own gratitude for having joined us this morning.
Thank you very much.
So, if see that post procedure patient CKMB was only 12,
Excellent.
yeah, and EF was 56.
I am sure so many of you who had requested a follow-up are satisfied. So this was the fate of the patient, did well and was discharged without any complications.
Yep. So, let's just continue knowing that this current case we need to work on. This is the patient, 58-year-old patient today, has class 2 angina and a positive stress test. He actually was catheterized outside in New Jersey, 3-vessel disease including left main, and was recommended CABG. So, rightly so, although he is non-diabetic, but he really wanted to look for, because of his age, he's, if I can do PCI option. So, he came to see me, and I said, you know what, we can look into that aspect. So, let's open, because RCA was total, and then left system, which we are going to do today, you will see it. I felt that let's open the RCA. If we can open the RCA, then we can go ahead and do the PCI of the left side. So, it actually RCA was diffusely diseased, totally occluded, and we did the angiogram. Show the last. And this is where now the RCA was nicely opened 1 month ago.
Excellent.
I got a
result
4
of the
stents.
right, yeah.
So, and we had cleared, kind of deal with him that if I cannot open RCA, a young guy, then he will go for surgery. So, since we opened it, so after the heart team discussion, he is now here for our left main intervention, well controlled on medication, and we actually are using the Seattle Angina SAQ score 7, which our nurse practitioners use it, and we have sent just one paper, abstract to the ACC, to see that when we do intervention, patient with a stage intervention, does SAQ change? SAQ change. So, very interesting observation, and rest of the good medical therapy on this particular case. Now, Anu can just show the rest of the angiogram, good LV function on this case.
This is the right coronary artery, and this is where we are with the left main. You see a distal left main involving definitely the proximal ostial circ in the left main. There is a ramus, which is, I would say, small size, significantly deceased, calcified circ, and then you have a large OM, which is significantly deceased, and the circ after that has ostial disease also. The question always is how is the ostial LAD involved? Based in the angiogram, so far it does not look like it is involved, but that is where we will be doing intravascular ultrasound to see that, and of course, we have one moderate size diagonal and a couple of small diags there.
Yep.
Couple of Samin questions for our guests there. David, I'll start with you. No doubt complex enough?
Yes, certainly complex enough, particularly if you look at the takeoff of the circumflex, almost 300 degrees backwards turn, and so that'll be a challenge when trying to work on the proximal circumflexes to make that turn and to avoid any complications.
So, David, where I want to specifically engage you in this conversation now, nobody I think could be faulted for sending this patient to surgery. However, you've got this institution with the most amazing record of doing these complex cases. I think everything was handled very nicely to first do the right coronary artery and then also to involve the heart team. Does that sound a reasonable approach to you?
Yeah, absolutely. As Dr. Sharma pointed out, this is a non-diabetic, and so there's a number of studies that would show equipoise between a surgical approach and a percutaneous approach. I think the other things he did are two, which are critical. One is that he involved the heart team, so he's got input from the surgeons, but then Importantly, the patient, right? We need to discuss with the patient what the options are, because one of the biggest drawbacks might be is if he needs another procedure down the road, be it from graft closure or from stent restenosis. So I think he's got everybody covered now, the surgeon, the patient, and of course the team here in the cath lab.
Excellent. Sunil, you wouldn't do this transradial, would you?
You know, I think it depends on what access site you're comfortable with. We probably would do this transradial. I think you can do it either 6 French or 7 French,
So
either sheathless or use
we
a
have
slender
at
sheath,
least
yeah.
2 persons on the planet, Sunil Rao and Tejas Patel, who I know for sure would feel comfortable. I'll have many other questions for you, Sunil, about the transradial approach, but Anu, what is your plan for today?
I am just going to IVUS the left main to LAD, then I will wire with the over the wire system rota wire to the left main to circ. We have 1 fiber from left main circ all the way to OM. Plan is then we see how it behaves and whether we have to do bifurcation stenting of the circ to distal circ or we stent across. Based on what the IVUS shows, then maybe even stent across from left main to circ.
Yeah,
David, would your approach be anything different?
No, I think it's right. As I mentioned, the bifurcation is what concerns me now. So I think the right thing is what Anu is doing, and that's looking at the origin of the LAD, not only to decide the extent of disease, but to see whether or not there's calcification there also. Obviously, one of the challenges will be when working on the bifurcation if a dissection occurs into the LAD, because it would likely go retrograde into the left main.
Exactly.
And since we have plan, actually initial our plan was we'll do 1/7 fiber from left main to the circ. Once we saw the calcium way from the proximal circ all the way to OM, we downgraded the.
Yeah, and the angulation of the circumflex. I mean, the very look at the 300 plus degree.
So, Samin, was there any consideration here? Again, I think the important fact was that LV function was completely preserved, but any thoughts about
Show the IVUS,
either a balloon pump or impella or something, or?
I think,
Well, same. Remember that question came on one
Many
other
times
particular
before.
case a long time ago that I mean, again, I think what you need to do is also, that
Can you
has been
play?
our point, is that teach what you do. So this case, whole idea is that I'm not doing something just to show it on the webcast, that what I'll do it in the daily life. And then of course we'll ask Sunil and David on this.
okay,
So
this is a ostial LAD.
Yeah. No, left main now.
Significant.
Let's
Now
see
left
the
main.
IVUS picture.
Yeah.
Yeah, there it was.
IVUS was not shown. They have to switch back to the IVUS.
You want to redo
No,
it?
but they have to play. Yeah, okay, IVUS play now. Yeah.
Okay,
Play
here
the
we go.
IVUS.
Yeah.
So this is
Okay,
in
this
the
is where we are ostial LAD. Stop there.
actually
Coming to
at the
distal left main.
bifurcation
Yeah,
level.
yeah, right there. No, but ostium is involved.
It is, yeah.
Yep.
Ostium of the LAD is involved.
Yep. Yeah, right there.
Yeah.
Ost of the LAD. See, angiographically it doesn't look like,
Right.
but it's quickly okay. Go.
And a 180-degree arc of calcium too, looks like.
At that level, and in the left main is actually more.
Okay,
so
give me the
clearly it's a
rotavar.
moderate plus calcification. But we know that angiographically the tight disease is in our the LAD. I mean in the circumflex side, so that that will be the area. Now knowing that LAD is ostial disease, okay, you want to change your strategy? How you want to do it?
No, what
two-stent
we could
approach
do,
of the
I
left
think we'll
main
do
later?
two-stent
Yeah.
approach of the left main, and let's do
Yeah.
one stent for the circ. Hopefully the distal circ.
Exactly.
We'll see how
Yeah.
after rota we
Yeah.
make a decision.
Yeah.
Would
Right,
you
of
be
the circ.
wiring the OMB or just keep just one wire down the circ?
No, one.
At the
We're
bifurcation.
going to go one wire into the OM now.
Perfect.
Yeah, I'll
All
take
right.
out the.
Excellent. So the focus has now shifted to the distal left main here on view of what we found on IVUS.
No,
David,
Sunil, let me ask that Sunil the
Yeah.
question of the 7 French.
Yeah.
How comfortable, although this patient, I'm sure the 7 French radial would have been no issue.
Yeah.
But you are okay with the going more and more radial even with the 7 French?
We either use the slender sheath that allows, makes a 6.5 French arteriotomy but allows 7 French guides to be placed, or we'll use either a homemade or commercially available sheathless 7 French system if we do 7 French.
So this one, I think you need to go prepared with the 7 French, particularly if we know that it could be a double stent of the left main. Other question could make it a point of even bifurcation. Somehow actually our fluoro is not great, just busted yesterday and we didn't want to change this. Remember last month we changed from room 2 to 98 episodes were done from this room. Only 99th did from that room and called left main dissection. So we actually have, skepticism and that we're not, because we have no left main or any vessel dissection with a guide catheter. It happened in the 99th, although that's my room. This is Dr. Keeney's room. So she said, even if it is bad, we're not going to ask them to change and let's just do the case. Cine is okay, but the fluoro is very grainy.
Well, it only tells us we still have things to work on.
All right. So with that note, let me just quickly go through. If we can go back to our slides. Syntax score was 51. Now residual syntax score after RCA intervention is 38. And patient is today. You go inside.
So what wire are you using here?
This is fielder.
Yeah. The fielder with a fine cross.
Yeah.
So they go same with the complex CAD. We do the calculation of the hard team discussion and calculation of the STS and syntax score, which both have been done. This patient has syntax score of 51, 3 vessel and left main, and STS is less than 1. So that way low risk, but hard team discussion and so now it still remain 3 vessel. So it's remember with the 3 vessel we don't have anywhere A. Even if you use the high ischemia. This is the latest appropriate guideline from your boss, Sunil. There should be at least in some cases with a normal EF, A. Patient is highly ischemic, so always remains M.
So if Dr. Patel is listening, I think we have some suggestions to improve the AUC.
So, but anyway, so I think, but it's a very, I would, and actually one of the biggest thing did, and I really congratulate him and of course the whole team on this, that they took away the angina class. So because it was so common, patient does not complain of chest pain, they all complain of dyspnea. And put everything together as a package, it's really very, very remarkable. So what after that, then I usually talk about 2 points, and today's the points are rotational versus orbital atherectomy data, and that is the latest trial of the secondary prevention stable CAD COMPASS trial, and we'll get knowing that it's on the bleeding issue. So clearly where do we use atherectomy? For the severely calcified, whether you do an angio, like case we saw, IVUS more than 2 quadrant or OCT, very demarcated radiolucent areas, although true quantification with the OCT is not possible, but at least on angiogram, the case which we saw, tram track is the severe calcium. And how do we treat those? By using a various non-compliant and cutting an angioscalp balloon, and truly high severe calcium by various atherectomy, rotational orbital, some cases done with a laser, and clearly we also know that if your balloon did not open your lesion, you can always change to the atherectomy strategy, and that has been part of our publication a few years ago in JACC intervention. So now the one actually, what do we do for the calcific lesion? We did this trial MACE, which is we are just making it final changes for publication. I presented last year, this year in the CRT, that we took 350 patients, asked the operator to identify, put in the category of the none, moderate or severe calcium, and see when you do what are your intervention you do and what happens subsequently. And we found that in this day and age, this trial done in 2015 end, 33% people are getting atherectomy, others 2/3 severe calcium are being done without atherectomy. Are you a little surprised? I was surprised. And actually, if you take, we did 50 cases of 350. If you take, we did 90% atherectomy. I'm sure that number goes down to like 25%. It's a little surprised with the severely calcium in United States. Still, we are doing it only 25-30% atherectomy.
Well, I think that the other issue is that a lot of these patients aren't even getting treated with PCI. So that's the so among the patients who are getting PCI, the use of atherectomy is very low, which is even more concerning.
Yes, no, that is true. So many of these cases just go for surgery, and we know that
or medical therapy,
or medical therapy. You're right. So, but key is now basically what we found, the gradient between the none, moderate, and severe, which is the purple bar, the severe calcium, lower procedural success, lower lesion success, and of course higher MACE rate at follow-up, which is with a TVR and MI. So what we learned basically from this MACE trial is the simple message that in the current era, only severe lesion calcification we need to worry about, mild or moderate, not an issue. So one simple message. Are you ready now? Okay. So now Anu is ready for 1.5 bar wire into the.
So that's why we use fielder fine cross. We cross the circ to the OM, change it to floppy wire. Same rota floppy. We have, so we'll be able to negotiate to that angulated circumflex.
I don't know if people saw this, but Dr. Kinney wired that back bend circ just with her fingers and not a torquer. So I guess for the fellows out there, that's career goals, is to be able to do that.
Sunil, we have been marveling on that for 100 consecutive cases.
So some cases of maybe CTO.
No,
you get the
no.
torquer.
You can go back and check all 100 cases.
Yeah.
No torquer.
Okay.
So tell us, what do you have in your roto mix here? I see it's opaque, so you must have some sort
So
of.
it's the Rotaglide, and then we actually still using the combination of verapamil, heparin, and nitroglycerin. 5 milligram verapamil, 5,000 heparin, and 5 milligram nitro in 1 liter bag, and the Rotaglide. So it's just same in the Viper. With the Orbital, we use only the Viper Glide, no other mixture. Knowing that still original paper many years ago we published those, that by using this combination you have lower slow flow, but that time we used to use a high speed. Now it's a 150,000. Go. So we're starting with the 1.5 at 150 RPM.
Same slow pecking motion. See that you are at the distal left main, going to the circ, pull back a little bit, go forward.
15 seconds.
Nice. That's it.
7 seconds.
Anu, what's the speed there?
155.
Okay.
And a 20-second run and wait. Yeah.
Now you have this significant, this is here, same.
54, 53, 5 seconds. 50, 48, 10 seconds. 46, 54.
So key is once you wait the burr between the runs, try to keep it in the normal segment, not in the lesion, because that creates a spasm and more probably platelet aggregation.
So I see that there's damping of the left. So
Main.
pull
Yeah.
the guide out a
Yeah.
little bit.
And key, the systolic pressure has to be above 100, and we know that we can have only 2 channels. By next month, hopefully we'll have 3 channels. So and the guy is listening, hopefully is the guy will come and fix it. We have 3 channels as of next month. Hospital has approved all the funding for changing the 3 channels.
The bifurcation side too.
Yeah.
49, 15 seconds.
David, any comments on the techniques of rotablation here?
No, I think since she has a small burr, I think it was fine to go at that speed.
Right.
I would just say for the fellows that you need to be a little bit more patient, especially with diffuse disease, especially if you're going to start with a larger burr.
Right.
I think one of the advantages of the smaller burr is you can go as quickly as Anu went.
Anu, I want to confirm with you, and then I have a question for Sunil. Bivalirudin in this case?
Yes.
So Sunil, almost I think all the 100 cases were done with bivalirudin complex coronary interventions.
Yeah.
Would you agree
Including
with that
CTOs,
approach?
including CTOs in our lab.
Yeah. So I think the latest data, I think the Validate trial from Sweden, the Sweetheart group, shows that they have equivalent outcomes, whether it's bleeding or stent thrombosis. Certainly bivalirudin is much more convenient. It's a very predictable ACT. Patients who are very heavy and whom you would have to repeatedly dose unfractionated heparin, there's a huge advantage. I think there probably also is an advantage of bivalirudin if you go with femoral access, which is what's being done here. So I think it's a perfectly acceptable strategy and potentially beneficial with respect to the bleeding complications.
With the much higher rates of transradial, what are you using at Duke?
So we've switched completely over. We were about 95% bivalirudin. Now we're about 95% unfractionated heparin. Some of that certainly is driven by our use of radial approach. Some of it also, I think, is just showing the data that the outcomes are equivalent. I think in a cost-conscious environment that we live in, unfractionated heparin has been preferred by many of our operators.
Right.
David, what about you?
So I don't think we're quite that far shifted. We're probably still around a third, I would guess, bival and 2/3 with unfractionated heparin. It also depends on whether or not the patients receive some kind of pre-procedural antiplatelet agent and what they received.
Well, also with the generic availability of bivalirudin, I think the cost differential has fortunately come down a little bit.
Yeah, but you know, it went down only 35%.
Right, it
It's
should
not
have
much
gone-
yet. You know why? Because there are only 2 manufacturers. One is still remain our the old friend, and then there is one more. So until you get 3 or 4,
Yeah.
the cost will not go down further. We actually at peak time when we used to do 5,000 interventions and using 95% bivalirudin or even more, we were the probably they told us that we are the highest user of the bivalirudin. The bill, the cost to Mount Sinai was like 6.5 million
Wow.
annually.
Wow.
6.5.
No,
Now we actually have come down. Many of the radial cases will go with the heparin, and then in the past, what we are also doing, that when you do FFR, it was practiced in the cath lab. Do that on bivalirudin.
Sure.
That was a killer.
Yeah.
So we say that if the low risk, that low prediction that you are going to have a FFR or less than 0.8,
Yeah.
do that on heparin, and
Yeah.
so. And we know the latest data also that about only 35+% done with the FFR in the PCI. So then, of the 2 techniques, rotablation and the diamond back orbital atherectomy, different plans, differential sending centrifugal versus differential cutting, bidirectional for the orbital, integrate with the rotational as you saw it here, and different wire, different burr sizes. Orbital is 1 single burr, 2 separate speeds, 80 and 120, but I can tell you we do not use 120,000 RPM. Speed wise, because that is what caused the perforation,
Right,
and with the
dissection.
80,000 is completely fine, and you saw it slow speed of 140 and 150. We know the problem with the rotational atherectomy in this calcific lesion in the slow flow, lower epicardial pressure to me causes. That's why never do rota teaching when systolic blood pressure in double digits. So give a neosynephrine injection. Original first trial of the RBAC, which I just showed for the
275, right?
historical for 20 plus years ago, showing that there was no difference. Rotablation did not make any difference in terms of TLR, but did make a difference in terms of procedural success. And since then, multiple papers have been published, including Rotexas trial, showed the same thing, the procedural success better with the rota and no difference in the outcome. Yeah.
So we wired the circ with the run-through wire going to the OM, and then filter from into the distal circ. Then we will dilate with a 27520 balloon, the circ to OM, and then we probably we have to do something to the distal circ, or we can just stent across.
I think I prefer doing a cutting balloon. We have a little different opinion. I usually do a little cutting balloon if the side branch ostium is involved.
Right.
And I know Anu many times feel dissection. Somehow I've been lucky in that way. I don't see the dissection.
Don't see
the
it.
put a stent.
That's
Yeah,
two
that's it.
different things.
I'm just saying, don't see. Even
Whether
if the sleep is like, I can't see. So I'm not saying it doesn't occur, but I can see. And has both strategies have been very good in terms of outcome, and we'll show it here.
Okay, go.
Yeah. So problem with the rotational atherectomy is the late loss, and I think this is where, whether it's because of heat generation or the way we do, has been a trouble. And now the new device we expect by first quarter of next year,
Here.
Rota Pro, easy setup. Right now there are multiple, so just like Orbital, everything will be on the table, and there is a little cart comes in, and then hopefully the Rota Wire Elite also comes back, which was there for a short time, but then they taken off because the tip was breaking off. So I think a lot of advances being done in the Rota area. Orbital, clearly it's the speed of the burr, which really makes the slow movement, which I say 1 millimeter per second. You advance, 20 to 25 seconds run, 3 to 5 passes. Once lesion crosses, compared to Rota, once you crossed it, it's not going to do much difference. Here, because it's elliptical, in various vertical area, will do a better ablation. The Orbit 2, the safety data with the 10% non-QMI at 30 days and good outcome at overall the lower TLR, and some complication did occur in terms of perforations, although slow flow, which we know is much lower with the Orbital, but perforation was about 1.8% as shown here, and 1 year data has really established the orbital atherectomy in our therapeutic armamentarium. More important, look at the TVR. TVR is about 5, 6, 8% at 1 year with the orbital, compared to every trial of rotational atherectomy, that number is 15 plus percent. This is actually the data of the Rotexus, Rota plus DES, TLR and TVR compared to Orbit, really whether it's something to do with the orbital atherectomy, which caused less subsequent restenosis, and of course short ablation time, less thermal injury, washout of the particle, and differential sending and small particulate size probably are responsible for some of the benefit we have. Although we don't have any randomized comparison, there is a new device in the OA group also, which is micro crown, which has an additional ablative tip at the ablative surface at the tip, compared to only in the center. Classic crown will be available probably again in the first quarter of next year, and we completed the study we presented last year, COAST study of the 30-day outcome in both Japan and US, showing the similar about 10% MACE rate. So overall, the data of the orbital atherectomy seems to be very positive, and most important being the lower TLR TVR. Now, Sunil, you have used this device. You want to comment on it? Is that your feeling compared to our Rota?
Sure. We participated in both the MACE and the COAST trials, and so our experience with orbital atherectomy has been actually very good. And we're one of the early sites that's using the microcrown now. A couple of things to keep in mind about orbital atherectomy versus rotablator. One is that, remember, rotablator is actually not FDA approved for calcified coronaries. It's FDA approved as an adjunctive treatment for coronary stenosis in patients who are candidates for bypass surgery. That's the actual wording of the gray sheet. So orbital atherectomy is the first device that's approved for calcification. The microcrown, the RPMs are actually quite a bit lower than the classic crown. The classic crown is 80,000, 120,000. I completely agree with you. We almost never use 120,000 RPMs. I think you do get more dissections, you get more perforations, or risk for perforation with that. The microcrown is 50,000 and 80,000. So the changes in the pitch as the crown enters the calcified area, you have to really listen very, very carefully to it. And you have to go even slower with the microcrown than you do with the classic crown. The nice thing about it, because we have a largely radial practice, is that it's entirely 6 French compatible. So if you want to get more ablation, you just do more runs. You couldn't go up to the higher RPM, as I mentioned. We don't do that. But that's one of the reasons why we've done a lot more orbital atherectomy than rotational atherectomy in our practice.
Excellent,
your
observation.
experience on these two devices?
No, mainly rotational. I guess once you start with these many years ago, 20 years ago, you stick with one.
Yeah. So, and clearly Orbital, the new micro crown will have a 50 and 80,000 RPM, and hopefully another device. So real, I would say, the proof of the concept will come from Eclipse trial, which randomizing patients with the severe calcium with the orbital atherectomy versus conventional angioplasty, including cutting balloon, but no rotational atherectomy, followed by DES, and has sub-study of the IVUS, about 2,000 patient trial, will be the first trial of its kind to show clinical benefit of atherectomy in these cases. So what about the comparison between two devices? There is no randomized trial, but we have some observational data. Actually, first we published from our group the small number of cases which showed that the orbital atherectomy does more deep cuts. Particularly this, we used about 30% time, 120,000 RPM. First experience, and it showed that it created a deeper cuts. In this group, we did not have any perforation, but clearly because of the deep cut, vessel enlarged, and the stent have a less malopposition. So stent expansion was better with the orbital atherectomy. Whether it translated into a lower restenosis, we do not know. Then second data from Columbia, so microvascular obstruction, they did a coronary flow and index of IMR, clearly found that orbital atherectomy has a lower microvascular obstruction or resistance compared to rotational, because rotational multiple particle. Then another small study comparing 100 plus patients, showing similar procedural events, little higher perforation with the OA, but slightly higher no flow with rotational atherectomy, which was part of our study of 1,000 patients, which published basically showing that all cases that orbital atherectomy is now being used in about 25-30% of our cases, and but the rota cases are a little more complex, and so the overall event rate, exactly what we talked, little more dissection with OA, slightly higher perforation, although slow flow in our study was identical between two, and more importantly, at follow-up at 6 months, we actually have just completed 1 year now, we have sent it to ACC abstract, that trend towards a lower MACE rate, largely driven by same, the lower MI and the lower TVR in patients with orbital atherectomy at 6 months. So I think it is this resonating that lower TVR somehow with the orbital atherectomy compared to the highest user of the rotational atherectomy in the world, that clearly we are seeing this, that lower follow-up event. So those are, I think, that our algorithm which we have published earlier also, that where you use rota versus OA, and biggest advantage of the OA is the ease of setup, not needing pacemaker, and this is our calcific lesion algorithm and so. So there is a new device which we all will be hearing very soon, is the lithoplasty or shock wave, which they use it for peripheries, and now soon will be available for coronaries, and with simple mechanism, balloon is little stiffer, whether it will be able to go to all the calcific lesion, but really disrupt the both deep and superficial calcium, and some data have shown it has been approved for the CE mark, and US is ready to come and start the trial. So second, quickly I want to go with the our secondary prevention of therapy. We know Karishma trial with aspirin Plavix and aspirin placebo, particularly patients who have prior MI, stroke and PAD, showed that patient with a definite CAD, you do better with the combination strategy, although overall trial was negative, largely because if you are asymptomatic, just risk factor, combination strategy was not good. And of course, post-MI patient really derived benefit. That led to the Pegasus trial, patient with MI 1 to 3 years and additional risk factor, found that ticagrelor 60 milligram twice a day dose was better. Of course, there was slightly higher bleeding, and that led to the third group, which is using the anticoagulant, which the Compass trial presented in European Society with rivaroxaban 2.5 milligram twice a day along with aspirin versus 5 milligram rivaroxaban or aspirin alone. And that really trial was event driven. They're supposed to go for 3+ years. They stopped early because of benefit of the combination strategy of rivaroxaban of 2.5 milligram twice a day along with aspirin 100 milligram. And you see all the primary secondary endpoint. The orange, the gray color is the combination strategy, and all primary endpoints were good, but bleeding still remain, as you can see here. So Sunil, with your expertise in the bleeding, anytime we have these agents, they do good from the ischemic point, but they increase the bleeding. Yeah. What do we do now?
Yeah, no, I think it's very challenging. I don't, there's no such thing as a free lunch with respect to these agents. And I'd be interested to get David's input on this too. I think the issue really is one of competing risks. So there are some agents, for example, which will not have any effect on ischemic endpoints but increase bleeding. There'll be some agents that will decrease ischemic endpoints, but in the overall analysis will either slightly increase bleeding or not have a significant increase. Ticagrelor, for example, in Plato, the protocol defined bleeding in the overall population was not different. I think when you have an agent that reduces ischemia and increases bleeding, the issue really is of competing risks. We need to see more data from Compass. I think the mortality benefit is actually very exciting here. We don't have the 2.5 milligram dose available in the United States. I have no doubt that it will be approved. And then it becomes a matter of figuring out which patients should get the agent. And that's where I think the next step is.
And for how long?
And for how long.
Right.
Yeah. Remember, in this trial, you could have had an MI in the prior, I think, 10 or 15 years or something to qualify.
Right. Yeah. So this is more with a known CAD, and they have all the multiple, two peripheral vasculature having involved and so forth, and MI anytime with a known multivessel CAD, diabetic, renal failure and so. So clearly the issue was the bleeding, and at least there was no higher fatal or intracranial bleeding. That's the key.
Yeah.
But other bleeding was higher, and this actually led to this new combination strategy, which editorial by Dr. Brownwald called it now thrombocardiology, a new terminology. So now an important step for thrombocardiology, that trial represented that maybe we'll be using this combination strategy in near future. So this always clearly, I would say, this field is exploring new options and so forth. And here we are ready with the AK, that what we need to do. Where are you now?
Samin, excellent and very comprehensive review of both important issues, and both David and Sunil, thank you for pitching in.
Okay, what are we going to do now?
Now same, even with the cutting balloon, we were not able to negotiate anything down to the
Right.
distal circ. So we have to decide here, are we going behind the distal circ
Leave it. No.
or we just stent across there?
Okay, stent across is
Probably
fine.
stent
Because
across,
we'll be
yeah.
using a 2-stent strategy for the left main. Yeah.
We had to do multiple, cutting balloon as well as a high pressure balloon to get anything down there. So let's see if one stent will take it,
Okay.
right?
What stent we need?
You want to go to
Xience?
275, 38?
Yep. Yep. Yeah. Is there a distal dissection?
I
Wire
think
is
so.
okay?
Yeah, yeah.
You want to do a
Little,
balloon there or no?
touch.
Okay, we have to balloon again, I guess. Now I
No, but
saw.
if your wire is distal, we can.
It is
just put a-
distal.
Then stent will go, right?
Yeah.
Or no?
Go Promus, right? All the time we use Promus.
No, but this one, since we use Xience, that's okay.
Oh, previous ones.
Yeah. Yep.
So
You know-
David, as they prepare the stent for the lesions, having picked up the job as the editor of JACC Intervention, really big shoes to fit in where Spencer King left.
Yeah, you're absolutely right. I was honored actually to learn that Spencer was here for the 50th case that was done with Dr. Sharman Keeney. So it's great for Sunil and I to be here for the 100th. So I'm just wondering if he's already figuring out for the 150th.
Yeah, we will book him now. You're okay? You have to pull the other wire out?
David, how do
I
you
went on the
continue
field
to engage the global audience with the JACC Intervention?
So that's a great thing. So I think just like with this here, being translated into Mandarin, for example. So we have JACC Intervention that's translated into Mandarin, but it's interesting that you ask that, that more papers actually come from outside the United States that come from inside the United States, and literally from virtually every continent there. So numerous papers. So how do we do it? I guess by trying to have associate editors from around the globe, from multiple countries, Asia, Europe, and of course North America. So I think it's trying to be involved, attending a lot of meetings internationally. Sunil the same way, trying to make it to the major meetings around the world to engage with not only the current generation but the next generation, right? So we need to be working with the young authors, the young reviewers, to keep them engaged into academics and with publishing.
Absolutely fantastic, and good luck with all these tremendous educational aims. Sunil, what's the nationwide statistic for transradial now?
Yeah, I think if you look at the first quarter of 2017, which is where we had the latest data from the NCDR, the rate is about 40% in cases with or without PCI, and it's 36% for PCI procedures. So that's an increase from 1% in 2008.
Just tremendous, and truly I want to compliment you. I think if there is one single person who's made the biggest difference in the US, that truly has to be you. What about for STEMI? What is the incidence there?
Yeah, it does tend to lag behind in STEMI almost by 8 to 10 percentage points. Obviously those are concerns over door to balloon time, people being worried a little bit about proficiency with the approach and making sure that they don't prolong procedure times.
Right.
So what we've tried to encourage is people to become proficient with elective cases with stable angina, or maybe even non-STEMIs that are stable, so they can learn to overcome challenges getting the guide up the arm and getting the guide seated, and then approach STEMI cases once they feel like they're comfortable enough to do that.
Fantastic. Sunil, staying on the bleeding and the other related issues, what's your recommendation and strategies at Duke with antiplatelets?
3528.
So
LED,
right
and
now,
there is a
all of our
3
ACS patients get one of the newer P2Y12 inhibitors. If it's
no,
loading in
23 will be too
the ED,
short,
we use ticagrelor. If the patient is
23,
going very
3 or
rapidly
23.
to the cath lab and does not have contraindications, we will use prasugrel in some of those cases. All the patients who are coming in for stable angina who are getting PCI will generally get clopidogrel unless they've had some reaction to it in the past. The bigger challenge, I think, for all of us now, and Dr. Sharma mentioned this briefly, is what do we do with the patients who are chronically anticoagulated? We have 2 trials now with rivaroxaban, actually 3, I guess, with warfarin, rivaroxaban, and dabigatran, suggesting that dropping aspirin is very safe. The Augustus trial is ongoing now with the pixaban. That will report out in a few years. But my sense is that we will probably approach a strategy where we'll be able to drop asprin and continue oral anticoagulation with P2Y12 in these very challenging patient
give us the
subsets.
stents.
Excellent.
So we'll go with the
3528.
3528 to the LAD, left main to LAD, and then we'll do 3023 from
No.
to the circ.
No. LED 28?
What do you want, longer?
No, short. Okay. So let's take a picture to evaluate now the stent strategy. You have the picture already. No, see the previous picture.
No, you wanted the length of the left LED.
Yeah.
Was on the IVUS was disease way
Yeah.
all the way.
No. Plus, yeah, let's decide now. Yeah.
Yeah, 23, 28
Okay.
up to the first circle.
Right. So 23, no, but the circumflex 23 will be too short.
28 maybe cover the distal circ.
Okay.
We don't
23.
want double stent
Fine.
at the
Yep.
distal circ.
Okay.
Right?
We'll do a mini crush technique.
Yeah,
Okay.
Give us
Agree
that.
or
Yeah.
no?
Yeah. So 23.
because otherwise you'll have too much crush in the left main
Yeah.
if you have.
But then
Right, right.
That's why I said 24 would have been okay if you were Roma. So we'll go 23 to the circ first. Same we'll go with the side branch, which is the circ now. The main vessel will be left main to LAD.
David, question for you regarding what is
23.
what's your thoughts and experience with OCT, and where is that finding a place as it relates to IVUS?
So, a great question. It's interesting how many of these technologies, once proven, still lag behind. I think Sunil alluded to it just a moment ago with radial access and STEMI cases. I mean, if there's any place that radial access was first proved to be of benefit, it was in primary angioplasty, but yet it's the one that's lagging behind. So too, whether it's IVUS, whether it's RADI, fractional flow, IFR, or OCT, even though they have established benefit, now we have 4 or 5 trials comparing OCT with angiography or IVUS showing benefit, but they still lag behind. I don't know if it's just time or experience, but it's interesting that many of these technologies, even though proven, they lag behind in practice. And the U.S. is guilty of this, as any country.
Right. I think one of the big challenges here, Dr. Mehta, is that we have a large proportion of lower volume operators in the United States.
Right.
And the important
I did.
aspect of that is that they tend to do more STEMI cases. So I certainly don't think anyone is advocating that they should stop doing angioplasty. They provide a very valuable service in maintaining access to primary PCI. The challenge comes with the more complex elective cases like this one. And in those cases, they either should do at a higher volume center, or they should refer to a higher volume operator where the results can be optimized by using intracoronary imaging that people are very comfortable with.
So that's a great point, and I was interested to see that something like 40% of all interventionalists in the United States are roughly doing 40 cases a year.
Yeah, right. Yeah, the median case volume in the NCDR is 59 cases, which means half the operators are doing less than that. So it's amazing.
Samin, just so that we stay on the 100th case in time, I am also happy to inform you that both Dr. Fuster and Dr. Reich have joined us in the room
Great.
behind.
Yes. The wire is okay. The LED wire.
Huh? Yeah, that's the way it's angular. Oh, it's in the.
Yeah, that's fine. We don't need to go any
We
further.
still
Yeah.
don't have to
So
worry.
we are doing a mini crush technique here.
Ready?
For the distal left main.
Yep.
Good.
For the distal
Engage.
left main.
Yeah. So 23 is just covering, right? But
Yep.
you will crush maybe a millimeter or so.
Yeah,
You
which is
want it
fine.
like that?
That's fine.
Okay, go. Go for the circ.
Yeah, I agree.
Well, welcome to both Dr. Fuster and Dr. David Rich. We are few minutes just off, but should be able to complete with the last. Now we are deploying the stent in the circumflex.
Okay,
Negative.
good. Done.
And
So
we
it's a
will now
nice
remove-
expansion. Same thing. We'll take out the balloon as well as the side branch wire, and we will crush the.
I think the important thing here is that the rotational atherectomy really allows your
Yeah.
stents to expand.
Precisely, yes. I think as
me a
Samin
new
mentioned,
one.
I
Get
think
me a
that
new
really
one.
is the differentiating
Ready?
point, that you're not looking at any difference in the TVRs, but it just enables
no.
a much
LED.
better expansion of the stent.
Yep.
We don't have to come up to the ostium of the left
Yep.
main. Some die. So we know.
David, now that you have watched almost the entire case, any comments about the format which we have chosen? As I mentioned before, 3 components to it. There is online feedback. I have been fielding numerous questions as they have been coming from around the world. The performance of the procedure and emphasis on the teaching techniques, and of course the format of the didactic.
Well, I think it's terrific, first of all. Secondly, it shows the mastery of Dr. Sharma to be able to multitask. He's got his left eye on the screen watching the procedure, but his right eye on the laptop watching the slides, and he's doing it both at the same time. So very impressive. I think one of the attractions for rotational atherectomy was with the bioresorbable stents.
Right.
In their lack of radial strength. I think in those cases, if the bioresorbable stents do make let's say a comeback and become more popularized, I think it will require operators to be very comfortable debulking lesions, especially like these.
And probably have a larger role for OCT too?
It could be OCT or IVUS. I think
Right,
anywhere
yeah.
where you're understanding the extent of calcification and the adequate deployment of the stent itself.
Ready?
David, another question for you. Again, angiographically the lesion is looking beautiful. One of the, where do you see, or for which audience do you think this webcast is more relevant? For the interventional fellows in training, or even for the more experienced operators?
No. I think, back to Sunil's comment earlier on, I think it's crucial for anyone. I mean, to get the chance to watch, a grandmaster working. The only thing I would say is that people can't try to, it's kind of like, don't do this yourself at home.
Precisely.
Right? So don't try to go as fast as Anu and Dr. Mehta are going. You especially with rotational atherectomy, you really have to take your time, be patient, make sure you're doing adequate debulking, but not so fast that you're sending a lot of debris down the artery and the microvasculature can't handle it. So no, I think if we've got a majority of operators who are doing a few cases, it's ideal for them to watch and to learn.
3520
And the beauty is they don't have to be watching it live, right?
Right. Well, the archived cases are being watched much more. And of course, the most amazing, I think, the development which truly increased our viewership globally has been the deep penetration into the various social media platforms.
So how about you, Dr. Mehta, with regard to primary angioplasty? I know you're one of the busiest operators in the world. What proportion of your cases are you able to do by the radial approach?
Because I have almost quit electives, I will never be as good doing transradial as I am more comfortable with the transfemoral. But that number continues to increase, and I do believe that having skills in both is the most desirable way to go.
Sure.
Which is where I have a lead-up question for Sunil. Sunil, what should be happening or what is happening with the training guidelines for fellows regarding transradial?
Yeah, that's a great question. So there's been very, very little change, if any. People have talked about it. I think the radial community has had some communication with the COCAT's guidelines. Right now, I think the wording is very general. It's vague. It says that fellows should gain adequate experience with different access sites, which unfortunately, or fortunately, depending on your perspective, the U.S. guidelines tend to be less prescriptive than the European guidelines. And so, there really hasn't been much of a change in what the recommendations are. What we have noticed, though, is a lot of fellows in training are asking for more radial experience, and I think they're getting a lot more of that in their training program. So they're coming out into practice being very, very comfortable with radial approach, which is something that even my generation was not very comfortable with at all.
So what in the vast experience you've had both at Duke, nationwide and globally, is truly patient preference the possibly one of the biggest determinants?
Yeah, I think so. Look, we can argue about whether you believe the clinical trial data. As Dr. Moderator said, the data support the use of radial approach in the high-risk patients like those with ACS and STEMI. But let's say you don't buy that information. I think the one incontrovertible proof that where radial really shines is with patient preference early ambulation. And so I think it's a very patient-centric approach. But I will say that it is important, as you said, to gain experience with both types of access sites. The current generation of interventionalists are going into practice, not just doing coronary procedures, they're doing endovascular procedures, they're doing structural heart procedures. Those necessarily require good femoral access skills. So it's important to get trained in both because, at the end of the day, that's largely what the patient remembers, is that initial stick.
Right.
The groin complication pain is the biggest one. Now we are doing a kissing balloon, with a 3.0 in the circ and 3.5 in the LAD, 16 atmosphere, negative, and just.
I mean, when you think about how quickly this case is being done with a syntax score in the 50s,
Yeah.
that's really pretty amazing.
Well, today it is a little slow because we are trying to converse with you and getting your wisdom across. But yes, it has always amazed me, both the speed and the skills.
All right, let's see it to believe it. We get nitroglycerin. You want to take a picture? Give the nitro first.
So this is another important thing for the fellows who are watching, and big balloons coming out of the guide. Make sure you
Aspirate.
purge the guide so you don't get air into the system.
Which is very common.
Yeah.
Otherwise, yes.
David, one last question for you. Had you expected the tremendous surge in structural heart disease?
Oh, I'm sorry, say the question again. Had I expected
The tremendous global surge in structural heart disease?
So I think it's not surprising. I mean, yeah, some people think it's a surge, but as you know, this has been going on now for 20 years. It's like the same thing with radial access. People say, so are you surprised by the emergence of radial access? And Sunil has a very great paper saying this emergence. No, it's more than, it's heading for 3 decades, right?
Right.
So I think this is I think what we'll see more interestingly is how this affects other areas. You know, does it affect pediatric cardiology? Does it affect congenital heart disease? Because, well, we obviously have a lot more older patients with structural heart problems, right? We have a pediatric population who is going to benefit from this knowledge, from this technology, from the experience gained with adults.
Anu, the bifurcation of the left main looks just perfect. Any concern about the proximal and the ostial region?
Yeah, that was a concern, you know, while placing the stent, whether we should have come up to the ostium or just fall short. But I still think maybe no more than 30%.
Yeah. So I
It'll be
think
okay.
no, but it is because the distal left main is minus now.
Right.
Yeah.
Yes.
This is the
Your
minus
reference is
20%.
bigger.
So I mean, no
Yeah.
dampening. This is okay. So with that brings to our quickly conclusion, knowing that our two
Yes,
the key-
Dr. Rich and Dr.
Yes,
Fustra.
all our the biggest supporter are waiting there. So let me just complete this. That the take-home message, which I conclude with the end of the presentation, that both RA and OA are effective adjunct to PCI in ablating the calcified plaque, and clearly the OA has an ease of setup, a small learning curve, and lower TLR with but higher perforation and dissection as in the literature at this time, knowing that there is no randomized comparison. An Eclipse trial will really answer this question, should we doing routine ablative technique, and will change the overall MACE. In the Compass trial, aspirin with low dose rivaroxaban, 2.5 milligram, which is not available dose yet, has shown to have better cardiovascular outcome, but definitely higher bleeding. So this will really improve the new field, getting more and more anticoagulants coming into the mainstream of our interventional cardiology. So quickly, 3 questions. Answers are always on the website, but key is the observational data comparing OA versus RA have shown the following, except means what is the wrong one? Lower slow flow with OA, lower perforation with OA, lower TLR with OA, similar procedural MI between OA and RA, similar procedural success with OA and RA. This is again based on the data which we showed today. Second, following are the potential explanation of the OA outcomes, I would say beneficial outcomes. Continuous washout of the debris, a small particulate debris, higher microvascular obstruction with more slow flow, lower heat generation, shorter ablation time. So key is that what is the wrong answer. The third is the Compass trial of the combination versus aspirin alone in stable CAD showed the following outcome, except lower death rate with aspirin, combo compared to aspirin, lower stroke rate with the combo versus aspirin, higher major bleeding with aspirin and rivaroxaban versus aspirin, higher the society bleeding criteria with aspirin and the combination, and higher fatal bleeding with aspirin plus rivaroxaban versus aspirin alone. So these 3 questions, answers will be posted to our website, and with that note we conclude about 10 minutes late in this case, which we started at 8 o'clock and
I just want to
finished
make
at 8, 9, 10.
the points here was same. Initially we decided we will do bifurcation for the circ, but this is an important point, that as you are doing the procedure, since we started having trouble in negotiating cutting balloon into the circ, we just did a balloon of the circ, and that's where we changed the plan rather than doing bifurcation stent of the OM to distal circ, just stent across. And same the IVUS, initial our plan was based on the angiogram that will stent across in the circ, but IVUS changed our decision that you will have to take care of the ostial LAD, where our plan changed that we will do the bifurcation stenting strategy of the left main to LAD. So the key point is the same. Whenever you are dealing with the left main and you think there is no access issue, that you should go with 7th French, you are able to change your keep changing your technique as you go through. But just to show with the newer generation stent, even despite us doing, since we did rotational atherectomy and multiple balloon inflation, the distal circ still looks very good. Patient, you can see at the end of the procedure, nice blood pressure, no EKG changes, and tolerated the procedure very well. Now he's had left main and multiple stents, he's already on the Efficient.
Yeah. Anu, excellent result, and I think that teaching point was very important, that modify your plan based on the imaging modality. I want to thank Dr. Rao and Dr. Moderator for having joined us. Samin, congratulations, 100 cases done, excellent work by your cath lab staff, including the fellows. We'll see case number 101 is going to be on November the 21st. There are two important matters now to proceed with. There is going to be a brief presentation here in the recording room, and Dr. Kinney, I'm going to invite her to come and
all right, we're coming there.
Replace me there, and she's going to be presenting the bifurcation app which is going to be formally released at this moment. And of course, as I had mentioned, Dr. Rich and Dr. Fuster are here in the recording room with us for a brief presentation to celebrate 100 cases of CCC live. I had also, there was a final picture which I had, which at one of the follow-up cases will probably show. I have a picture of myself in July 2009 and today, and it is the same suit and the same tie. Of course, there has been, the hairline has receded, very painful to my observation, but beyond that, I am glad 100 cases has truly been a most remarkable journey. The amazing part is that each case has been absolutely uninterrupted. There has never been any editing, and I simply cannot thank. There was a time I used to average out how many questions were sent by our global audience. That has often varied with the, as sad as it may be, the questions start coming up whenever we have a complication. So that actually makes my task extremely challenging. There are all sorts of options coming up. In case 99, we continued to get questions as to, are the surgeons in the room, what was happening, and I am so glad that the outcome of the patient was just fantastic. A few more other notes as Dr. Kinney is going to join me to release her app, is that continue to ask questions. I think that is one of the most engaging ways, as I had mentioned before, that is an essential part, our promise and our commitment to you that we'll try to answer all of them. I have normally grouped it in two categories. I kind of triage them. The more relevant ones I'll ask Dr. Sharma and Dr. Kinney, and they answer online, and some of them just because of the requirement of time, I answer them online on computer. With these closing words, we'll proceed now with Dr. Kinney to make her presentation with the app, and I am going to step off. It's been an honor doing this for 100 cases. Anu?
Good morning, everybody. Having completed the 100th case, we also have an opportunity from Mount Sinai Heart to release what is called as a bifurcation app, the Bifurcate. If we can start showing it, right? So as you see this, It contains, you have a main menu tab which is on the left hand side. You'll see the home tab. As soon as you see the home tab, what you'll see, you'll have two sections which will be left main and non-left main. So this is how we decided that when you are dealing with coronary bifurcation, you essentially decide whether you're dealing with left main bifurcation, the one which we showed, as well as the non-left main bifurcation, which was also showed today. They're doing the circumflex, where we decided we'll stent across the circumflex. Then we go back to the basics. So if you go to the basics, this is a very important section where it's a description of the bifurcation itself, where you will have guide selection, wiring technique, the balloon selection and sizing. Various bifurcation stenting technique has been described here, which is just part that before doing any kind of bifurcation, you understand what each technique means, and subsequently managing the complication of any bifurcation. So if you see that. Now if you go back to the home page, it's where it is, which is very simple and intuitive. If you go back, just let's go to the left main, just click left main. So the entire bifurcation was based on Medina classification. So you can, depending on the angiogram and what the Medina classification shows, then we can decide how you are handling the patient. In left main, we just decided that you will deal whether it's a stable patient or unstable patient. In unstable patient, there's only one technique, which would be SKS, that you do not have time to decide what would be the best technique for this patient. Go ahead and take care by doing two stent technique, and everything has been shown here. So go back to the most important feature of this application would be a tracker. On the top, so if we go to a stable patient and we've decided, you go 111. So we've go 111 and decided it's a stable patient. We decide that we want to do a minicrush technique. So on the top you see the tracker, which is on the, then we will say we'll wire both. Go to the next. So the tracker actually on the top is going to tell us that which part of the application you are on. So you want to go back to Medina and change the Medina classification, go to, just click 111. And go back to one of the 111, stable, minicrush. Just go, we are going to balloon. Just to show the hyperlink. Yeah, just go to the stent, side branch stenting.
But I'm sure that everybody will go through. This is the first time being here.
So if you have a hyperlink connection here, and this will go back to the hyperlink where it will show us exactly where you're showing a wiring or a rewiring of this branch, and this is a very intuitive one that we have done. So I just want to introduce this, and the mastermind behind this entire bifurcation app would be the Mount Sinai Heart Cath Lab, which would be myself, Dr. Samin Sharma, and we have our two fellows, Samit and Surbi. So it's our great pleasure actually to release this app today on this very auspicious Diwali day, and the app will be now available to free to be downloaded from App Store as well as Google Play. Thank you.
All right. With that note, the great development and from Mount Sinai knowing, and we actually to congratulate and to celebrate this 100th episode, we actually have two great I would say mentor, colleagues, friends, and so one our president of Mount Sinai, Dr. David Rich, who is anesthetist by profession, and he's actually doing the anesthesia downstairs, but he came for half hour here, and then Dr. Valentin Fuster, with the director of Mount Sinai Heart and physician-in-chief of Mount Sinai Hospital. So clearly they will, we have requested them, their presence for this special occasion with the two great guest faculty to come here, say a few words, and we have the memento by both of them will be given to us. Dr. Rich?
Thank you so much. Thank you, Dr. Sharma. I'd like to congratulate Dr. Sharma, Dr. Kinney, and Dr. Mehta on the significant milestone of reaching 100 live cases of this extremely well noted educational monthly webcast program, CCC Live Cases. The case series has shown a very wide series of complex cases presented in an interventional format consistent with the guidelines for appropriateness of coronary revascularization, and it provides a unique experience for learners. The learners are guided through an actual clinical procedure, and the cases are selected by Dr. Sharma and Kinney themselves and incorporate current complex issues that clinicians face in the cath lab. Every third Tuesday of the month at 8 a.m., they've consistently performed these increasingly complex coronary cases live from the Mount Sinai Heart Cath Lab, along with the educational lectures that accompany them. They started this live monthly webcast in 2009. I already heard a comment about hairlines, etc. I just don't look at old pictures. That's my advice, Dr. Mehta. It works very well for me. But last month, CCC Live CSAES.org reached over 10,000 page views. That's rather remarkable. That was in September, with another 7,000 views on the YouTube channel. And we now reach 130 countries, which is just an incredible global outreach. Today, we're lucky enough to have two special guests, Dr. David Moliterno and Dr. Sunil Rao, who will be giving lectures right after our presentations on the history and the future of interventional cardiology, which we will record and post to the website later today. So thank you for joining us this morning, and I'd like to congratulate Dr. Sharma, Dr. Kinney, and Dr. Mehta on this incredible achievement. So in honor of that, we, of course, have to have an award. Yeah. So I will start by giving some awards. Yeah. Okay, an appropriate amount of applause. So let's say, so we're going to start by giving an award to our leading moderator, Dr. Samir Mehta, MD, FACC, MBA. This award is given for his outstanding contributions to the education of physicians in interventional cardiology. This date, October 17, 2017. Thank you, sir, for all that you've done. And now, if I could next give an award to Dr. Sharma. This is the Master Teacher Award to Samin K. Sharma, MD, FSCAI, FACC. This award is given for his outstanding contributions to the education of physicians in interventional cardiology. This day, October 17, 2017. For you, for Dr. Sharma.
Thank you.
Thank you so much. And then finally, definitely last but not least, I work very closely with Master Teacher and Operator Dr. Annapurna S. Kinney, MD, MRCP, FACC. This award is given for her outstanding contributions to the education of physicians in interventional cardiology, October 17th, 2017. Dr. Kinney, congratulations.
David, thank you very much. I know you have your OR schedule very tied up, but
even more than stethoscope today. So everyone, thank you for all that you do, and I'll try to do the cardiac anesthesia part while you do the interventional cardiology part.
Thank you. So now we ask my mentor and of course the great person in all the way, everyone knows globally, Dr. Valentin Fuster, to say a few words, and then we also getting award from Dr. Fuster.
Okay. Well, thank you very much. I still remember the beginning of all of this. I was approached, I think it was in 2008, about such possibility. And I was very excited about it because I thought this was going to be successful. When you began, and I still remember the first day, in 2009, the question was about the audience, whether this was going to click. Now, as you learned a minute ago by Dr. Reich, about 10,000 people, I think, watched this last month. Is this correct?
Yep, yes, that's correct.
In 130 countries. So this speaks by itself. I think there's no question that the objectives were met, and this will continue to be so. I can only say that I know these characters very well here. They deal with you about complex disease. This has been really the appropriateness of dealing with complex disease is very complex. and the fact they have shown you case after case dealing with this aspect, and certainly quite educationally. But I will say you something. As complex as the cases are, this is the most smooth running lab I have seen in the world. It's very, very smooth. You come here early in the morning, you get into the lab, you see the people, everybody with a smile, no anxiety, really being present, and it's wonderful to have this feeling very early in the morning when you come here. So it's actually quite of a paradox. They work on complexity all the time, but it's so smooth the way this lab is being run. And this is the reason why not only I want to congratulate all of you for the webcasts, number 100, but I want to congratulate all of you for what you have achieved here at Mount Sinai. We all feel very, very proud. Well, now I have to give you a certificate to be sure that you were present here today. Okay, so. Yeah, you really deserve congratulations. You know, I saw you every third Tuesday around here. I say hello, you say hello, how you are doing? I'm doing fine, let me move on. That's what you always tell me.
Absolutely.
Well, anyway, let me give this to you by being what here they said, leading moderator. You really look like you have been working in ABC, NBC, and all of the CNN. Is that right? You do very, very well, frankly.
It's been an honor, and I'm so glad to have received your support.
Congratulations. And then the next one. Oh, yes.
He actually, in his speech, before we started, about 6-7 minutes, he put everything together. And the last statement was that your support for this.
Oh, absolutely.
It was your support, your guidance, and most of all, your blessings.
Thank you very much. I feel very motivated because you motivate me. It's like a motor engine, you put the gasoline. Anu, I remember you when you were a baby. Yeah, absolutely. She was a fellow. An interesting fellow. I prefer not to comment about details, but she really was something that I said, she's going to make it, no question about it. And here we have you very successfully running with Samin and this program, and I want to congratulate you. The certificate says a master teacher and operator. I agree.
Thank you.
Thank you. Okay, thank you.
That means a lot that coming from Valentin Fuster, that he agrees with what he has presented to me. Thank you.
Thank you. Yes, I mean, yeah. I know you when you came in asking for a job. He came in asking for a job, and he says, I will work for free. And he ended up in the nuclear lab. This is how Dr. Sharma always started. And he created a revolution in the nuclear lab. It didn't work for a number of years. In about 3 months, it was a completely different lab. Then he came back to me and says, I want to work on the coronary and cardiac catheterization laboratory. And I said, what are you going to do there? And he didn't answer. I said, are you going to create a revolution? And he did. And here we are today, how many years after?
It's 1988, 89, and now it's just 30 years.
Yeah.
29, 30.
I feel very proud of what you have done, Samin, and congratulations.
Dr. Fuster, clearly, I thank you for all your wisdom, guidance, and mentorship, which has led to, and critical analysis throughout. It's not only the mentor doesn't tell you just all good things you do, also where you need to improve and focus. And that has been the great advices and the tips, I would say, I received from Dr. Fuster over the last 30 plus years. Many times we meet very early morning or the weekend, Sunday, the usual time. When Dr. Fuster is here, I'm here. We always meet on Sunday and work out various strategies. Dr. Fuster, once again, thank you very much for giving this honor and, of course, all the support throughout.
It's a pleasure.
Yes.
I'd like to finish about these two characters here. Really outstanding internationally. You know them. They have been introduced. But I have to say they work on the journal that I am the editor-in-chief. This is Jack. Okay, Dr. Moliterno, as you know, is the head of the editor-in-chief of Jack Intervention. And Sunil is actually associate editor of Jack, and he's in the phone every Tuesday at 4 o'clock, and today you cannot miss it. Don't make any excuses, all right? Or you stay here, or you leave now and then be on the phone. Okay.
His plane reaches there at 3:30. So
yeah, and I really appreciate very much your presence here today, because it gives a flavor of something that is really international. You are international, and I think we feel very proud both of you accepted to come here today. It's a great honor for us, okay?
Thank you very much.
Thank you very much.
All right.
Thank you.
Thank you.
Okay. Thank